We've talked about induction a lot. We've touched on transplant. We've talked about MRD negativity. What about consolidation therapy? So you've got a good but not complete remission after your initial therapy, perhaps particularly in the elderly. How much consolidation therapy? Are you going to escalate treatment at that point, Tom?
Well, you say in the elderly. So in the elderly, I'm not usually doing any form of consolidation-based therapy. They get their 3-drug regimen for anywhere between 8 to 12 months to get their initial response. And then after that, I'm trying to pick the 1 or 2 drugs that are the best tolerated and continue on in that
What
group.
about in the younger patient?
Yeah, in the transplant ineligible, so we have some controversy, obviously. The EMN trial showed that consolidation, the EMN trial from Europe, where they did not use a PI and an IMiD as induction therapy, showed that potentially consolidation therapy using an IMiD has perhaps some improvement in PFS. However, in the US study, the Stamina trial, where the majority of patients received a PI plus an IMiD as induction therapy, there really was no benefit to consolidation post-autologous transplant.
What's your opinion? Let's get practical here.
I would say that it really depends on, for the younger patient, how much improvement in their disease burden they've had. If they get induction therapy, a transplant, and they still have measurable disease, then yeah, I would give them consolidation to push their disease down further. And I would change, if it was RVD transplant and they're still in PR or they're in VGPR, they still have something measurable, I'm going to give them KRD for a few cycles to try to get them to that low point and then put them on maintenance.
So this seems to be the trend. We used to give hit and run therapy, 4 months of treatment, a transplant, we'd stop. There's usually more and more of a trend to treat for longer, Adriana. What's the right duration of consolidation and maintenance therapy? What do you think?
I would love to answer it. My answer is it depends. Again, on the patient, I think response, my goal in a transplant eligible patient is to get them to that MRD negative state. If I can do it with an induction, I may defer a transplant. If I do it with an induction and a transplant, I will certainly maintain. If the induction and transplant doesn't get me there, I do start a second triplet, and it may actually be KPD if VRD didn't do it, to try to get them to that MRD negative place.
I must say, I differ from my colleague Raphael here, is I don't do a day 100 MRD test because I pretty much giving everybody consolidation, so I don't see any point in doing it 100 days because it's not going to change. I'm going to give them consolidation anyway, so I wait till after that till I even test. But
how many cycles of consolidation do you give in that scenario?
4 usually, and then I test maybe 6. Transplant 4 more cycles, and then I'll test and see how much further do I go.
So here's a suggestion, because sometimes MRD can measure, has some quantity aspects to it. You could measure, and if it's positive, and you give consolidation, then you can gauge if your consolidation will work versus not, because they may be in the subclinical level. So they may be in a CR with 100 cells. You give them, a DARA combination, they come back and they're 150 cells. But if you don't have the baseline, you don't know.
If your patient's MRD negative at day 100, are you not going to do anything? Or are you just going to go right to
No.
maintenance?
But what if they're positive? If they're negative, I'm still going to go with a consolidation. And in fact, one of the points I was going to make is semantics, right? There's trials that are designed to test consolidation, like the BMT-CTN trial that has its 4 VRDs post-transplant. But then we have the trial that we have referenced now 3 times, the one from Dr. Gay here. That actually was consolidation post-transplant, the KRD, transplant, more KRD. So in short, I'm doing consolidation, but I do like to know where we start. And we're doing the testing, once a year for the MRD just to gauge where we are.
So we're getting real close to total therapy here.
Well, I was going to say, that's good to know we were right.
Therapy,
But
yes.
I'd like to kind of just take Tom's idea that a little bit further, because I think one of the things, if you think of it from a biological perspective, one of the things that consolidation can do is if you change it up a little bit, your assumption is that you've maybe got some stray cells. They didn't respond, those stray cells, to your induction therapy and your transplant. And so presumably they may be resistant to whatever you use. So changing up your consolidation a little bit, I think, is important.